Hey everyone, welcome back to Karan Academy. My name is Karan. I hope you are all doing super well. Today we're going to be talking about obstructive sleep apnea. Now, this isn't a super high yield topic for your matrix. However, it's one that you'll encounter very commonly. This is probably going to be more relevant for your fourth year general practice term. But again, you would see cases in hospital where patients might present with something else and have this as a comorbidity. And this is one of those things which can often be missed quite commonly. So knowing what to do and what to look out for is super, super important. So let's break it down. As the name suggests, obstructive sleep apnea, you have an obstruction, and that's typically in the upper airways. And when the person sleeps, they become apneic or breathless, and they have these typical breath-holding apneas. So, well, why does this happen? Why is there the obstruction to begin with? And the typical cause for that obstruction is the collapse of the pharyngeal musculature. So around the pharynx, you have your pharyngeal muscles, which collapse in these patients, and you end up with an obstruction. But then that makes me think, well, why does it only happen when they're asleep? Because this is obviously not purely positional because they're laying down. Because when they're awake, they're fine. But when they fall asleep, they have these issues. So firstly, one of the biggest contributing factors to OSA is obesity, particularly having a wide neck diameter or a circumference, neck circumference as well. What happens is all that fat is pushing your pharyngeal musculature inside because remember, most of this fat is subcutaneous fat that's on the outside pushing in. Additionally, the person may have had some previous airway surgery that's again contributing to that. They might also have some other issues at play. So something that's not necessarily pharyngeal, maybe it's slightly higher up. So especially in kids, you can see adenotonsillar hypertrophy, which is a common cause of OSA in children and teenagers. You can have nasal septum deviations, acromegaly, and goiters. So something is compressing, right? But let's understand why they have this particular issue with the pharyngeal musculature, because it's, I think, really good for explaining the condition to the patient, but also it's relevant when we talk about treatment. So as the patient's falling into REM sleep, what happens is that you are overcome with a wave of relaxation of skeletal muscle. Your arms, your legs, most of your muscles start to relax. That the same thing applies to the pharyngeal muscles. Now, usually the neck has enough supportive structures to prevent the muscles from collapsing when they relax. Because when they are not relaxed, when they're constricted, they're nice and firm. But the moment they relax, they should be held back. However, in these patients, that doesn't happen. And what usually happens is that you gradually have these pharyngeal muscles collapsing, and that leads to hypopneic episodes where they have the difficulty breathing. And as it fully collapses, you then have a shut airway, and that's when they have their apneic or breath holding spells, from which they usually wake up. They might be gasping or out of air, and this wakes them up out of sleep. And then they go back to sleep, and then you have a cycle of that happening again. Now, this can happen anywhere between a few times an hour to a few times a minute. And as you can imagine, that's quite debilitating because every time the person goes into an apneic episode, they usually wake up. Now, I shouldn't say fun. The interesting thing is that if you ask these patients, are you waking up? They might say they're not. And that might come as a bit of a shock to you because you might have a partner who's telling you that this patient is waking up gasping for air every few minutes, but they don't remember this. So that's really important to know, especially with patients who sleep alone. So how does it present in terms of its symptoms? So what symptoms would the patient have for you to think, hey, could this be OSA? Obviously, if they're having these obvious spells that's reported by either the patient or their sleeping partner, that's obvious. But usually they might also have restless, disturbed sleep. And that would eventually cross over into their behavior in the day. Snoring, excessive sleepiness during the day, because as you can imagine, anyone waking up that often is not going to get a good night's sleep. And a very typical
presentation, which I've seen many times with my GP, was, hey doc, I am getting 8, 9, 10 hours of sleep, but I am still extremely tired during the day. I'm falling asleep. And then you think to yourself, hey, could this be OSA? Poor concentration, headaches, partly because of that sleepiness. And a really interesting one, hypertension. Now, a lot of these patients tend to be hypertensive. And surprisingly, it's not hypertension because of their obesity. It's much more than their obesity. Now, let's talk about that for a second because it's important. Uh, Let me rephrase. Let's talk about that because it's interesting. It's not really super relevant to know and doesn't come up on exams, but I think it's one of those things that's quite interesting that doesn't usually make sense until you think about it a bit more. So OSA is one of the leading causes of secondary hypertension. But what actually is happening here? So as you already know, every time you have an apneic episode, you desaturate, right? And that's one of the things we measure for during the sleep study. And every time they desaturate, that's why they wake up and are gasping for air. However, you, on a physiological level, are having a state of repetitive hypoxia over the night. That is going to trigger a sympathetic response. What happens in that response is you have increased pulse pressures, which means your heart is going to be pumping harder. So the difference between your systolic and diastolic pressure is going to increase. You're going to have the release of renin and aldosterone because your body is going to be thinking that you are hypoxic and you want to increase both the blood pressure as well as the oxygen saturation. And you also have vasoconstriction because of that sympathetic tone. You also release a whole bunch of catecholamines during this process. Now, all of this starts off as hypertension. That's purely when you have these sympathetic response episodes, right, which is in the night. And if you were to do a 24-hour blood pressure Holter monitor, you would notice that people with kind of at the very start of this would have high blood pressures only during the night or nocturnal hypertension. However, over time, this crosses over and leads to general hypertension because they now have structural issues that are not just this sympathetic response. They might have inflammation, oxidative stress at the level of their arteries and arterioles. They might have generally higher levels of renin and aldosterone that are circulating, and vasoconstriction that might be more permanent. So all these factors contribute to the development of long-term hypertension. In terms of taking good history, you want to always try and take a collateral history from a partner if they have one. You want to assess their comorbidities. You want to exclude any other obstructive causes that we talked about earlier. So check their, assess their throat, check for any lymphadenopathy, assess their thyroid, assess their nasal septum, their tonsils, just make sure that there's nothing else causing it. Most cases, this will be fairly unnecessary because the cause would be your typical stock standard middle-aged patient with obesity, but it's still good to rule out. Then you also want to be asking questions on how badly this is affecting them, which will help kind of gauge how severe this is and how aggressive you want to go with your intervention. A very useful tool used by most GPs is the Epworth Sleepiness Scale, which I've shown here. So you ask them a set of questions, you provide them with situations and ask them how likely are, or what are the odds on a scale of 0 to 3, how likely are they to just doze off in the following circumstances. So you start off with something that's relatively, I don't know, like sitting and eating, or sitting and reading, watching TV, and then even sitting and talking to someone. So as you can imagine, if someone's falling asleep while they're talking to someone, that is going to be a really grave cause for concern. Also, you should be asking whether these patients are driving, because if they are driving and they have severe OSA, they obviously should not be behind the wheel. However, the real bang for your buck is going to be with a sleep study or polysomnography. And this involves, firstly, a few monitors. So you have an ECG, an EEG, you have oxygen saturations being measured. It would tell you when you are desaturating, also electromyograms, which tell you, are you waking up or jerking? The really good thing is that they can pick up also desaturation episodes in addition to obviously you just waking up. And it can also pick up arrhythmias and seizure disorders, which can often be triggered by hypoxic events. That's good to know. You can also, and these are usually done on the wards or in a lab. You now also have in-home sleep studies that are not as extensive, but then still have the O2 sat probe and an ECG monitor, perhaps. And we, from that, use the AHI score or the apnea hypopnea index to assess their severity. And that's the number of apneic episodes plus hypopneic episodes per hour. 5 to 15 is mild. Anything more than 30 is severe. And as you can imagine, desaturating or waking up more than 30 times an hour is going to be quite debilitating for your patients. In terms of treatment, you should be treating all patients with OSA. So there is no kind of lower upper limit. If they have OSA, you treat them. Your first line therapy is always going to be PAP or positive airway pressure. And the way I like to think about this is by applying positive pressure inside their throat, we are kind of preventing that pharyngeal musculature from collapsing every time it relaxes in REM sleep. You can use two types. You can either use a continuous positive airway pressure or a bilevel airway pressure. Continuous positive airway pressure, or CPAP, as it's more commonly known, is the more widely used and preferred tool. And in addition to these devices, lifestyle therapy is really important. So talking about weight reduction, talking about alcohol consumption, exercise are all very important. You then also have the next step up, which is kind of more aggressive stuff like surgery, but that's often only reserved for end stage. And you would have to trial something like CPAP before that. There are a few other tools like devices to keep the nose open, or devices that kind of help you sleep on one side, because that apparently helps a bit versus sleeping on your back. But again, when it comes to your level, what you should really know are both to be able to obviously know and explain would be your positive airway pressure machine use, why it's important, how it's used, all that. And I think that is the end of our presentation on obstructive sleep apnea. I hope that helps. If you guys have any questions, please feel free to get in touch on my email or on Facebook. I'm always more than happy to answer any questions you guys may have. And as always, please look after yourself and please look after your loved ones. I'll see you in the next one.